So the last conversation that we need to have after looking at those x-rays is just a continuation or the completion of the vascular diseases. Specifically, I want to talk about aneurysms and dissections. Okay? Some people tend to talk about these like they're the same thing. Oh, thanks for getting the door there. But they're actually not. An aneurysm is not a dissection is not an aneurysm. They can present very similar. They can have very similar presentations, but the pathophysiology is very different. So let's talk about aneurysm. So an aneurysm is a local dilation. It's a local dilation and expansion of an artery. So basically you have a thin pouch or pocket, outpouching that develops. And it tends to develop where you have bifurcations, okay? So where you have smaller arteries or other arteries bifurcating off of one another, okay? And you can get this small, initially it starts small, it becomes dilated, and as it dilates out further, it becomes weaker and weaker until eventually what may happen? That weakened area can rupture, and you can have hemorrhage and possible exsanguination occurring. Okay, you guys okay with that? Now, the specific pathophysiology is not particularly well understood, but that's the basic picture that we see. What are some risk factors? Age is one of our biggest risk factors. Okay, greater than 55 years old if you're a male, and greater than 70 years old if you're a female. Okay, guess what? Tobacco, hypertension, atherosclerosis, and arterial sclerosis.
Chris,
family history, yeah.
on that risk factors, I noticed you used tobacco, not necessarily smoking. Is that just tobacco in general?
Yeah, well, tobacco in general, yeah. But obviously smoking is the major form of tobacco use. But yeah, you know, to some extent, snuff, chew, those kinds of things. But smoking, you know, by far is your biggest factor for sure. And there's some genetic disorders such as Marfan syndrome. And this is actually even more relevant when it comes to dissections, but I kind of threw it in there. Okay, so what are signs and symptoms of aneurysms? Well, here's the bad news. Yeah, generally if it's not causing a problem, i.e. it hasn't ruptured or it hasn't leaked, your patients are going to be asymptomatic. Yeah, asymptomatic. They're not really going to have much going on at all. They're often asymptomatic. Some signs and symptoms can be very nonspecific. Occasionally, and I actually have seen this in my career, an aneurysm was found upon physical exam. It was, I was working in the emergency room, and an older lady came in, and she was having some GI. She had vomited, and she just wasn't really feeling well. And the physician, the ER physician, who happened to be a surgeon, who was a general surgeon as well, a general vascular surgeon, ended up doing an abdominal exam on her, and he felt a pulsatile mass in her abdomen. And he ended up ordering a CT scan and all that, and lo and behold, guess what? She had an aneurysm in her abdomen. Now, the aneurysm was not really causing any problems. It wasn't causing her pain. She had viral gastroenteritis. Yeah. So the aneurysm he just happened to find it by doing a good exam, and then ended up referring her to a thoracic surgeon or another surgeon to have the repair done on that. So it was kind of a coincidental finding. But a pulsatile mass, okay, in the abdomen tells you that you may be dealing with an aneurysm as well. So if you feel a pulsatile mass, generally just don't feel anymore, right? Don't feel anymore. You felt it, okay, whoop, okay, yeah, leave it alone. Now, if the aneurysm ruptures, what do you suppose is going to happen? Yeah, typically it's a very acute situation. Your patient will acutely decompensate, okay? They may develop severe pain. Pain tends to radiate to their back. Prior to rupture, they may kind of have a constant gnawing kind of pain, like something's gnawing or chewing at me. And then when the rupture occurs, they tend to decompensate very rapidly. Now, occasionally what can happen is if it ruptures, if a thrombus develops and tamponades that rupture, that may preserve their vital signs in their life, and they may end up being able to survive that. In general, mortality is over 50% though. All right, so over 50% of these people don't make it to the hospital. So it's very high mortality if you have an acute compromise to an aneurysm. We have different types of aneurysms of the life-threatening. We have them everywhere. You could have an aneurysm anywhere and everywhere. But the ones that we're really concerned about are abdominal. And these are called abdominal aortic aneurysms, or sometimes abbreviated AAA. You see that in a patient's chart, that's what they're talking about, okay? These tend to be fairly common. These are a lot more common than, say, an abdominal, or what we call a thoracic aortic aneurysm, okay, which is along the aorta in the thoracic cavity. These tend to be a bit more or less common. And because the signs and symptoms are either asymptomatic or just kind of really nonspecific, guess what? Misdiagnosis is very high. Up to 30% of these can be misdiagnosed as something else. Some sort of viral gastroenteritis or heartburn, or just some other problem that we think is going on. So they're really tough to figure out what's going on. So how do you think we need to treat these if we have somebody? We suspect they may haven't had an aneurysm, maybe it's rupturing or it's compromised. What kinds of things need to be done? Supportive care. What next?
Fluids.
How do we want to fluid resuscitate somebody who's...
Titrate up the BP with...
Do we want a normal blood pressure?
No.
Why not?
The hypotensive. It's the permissive hypotensive.
There we go, right? Permissive hypotension. You guys are familiar with that concept? So in general, we're shooting for around 90 on your systolic blood pressure, around that, 90, maybe 100, okay? So we will give fluids, we'll titrate fluids to not a normal systolic pressure, but a systolic pressure that is on the lowest end of normal. And why? Why do we do that?
Because if the thrombus has been created, you don't want to blow out any clots.
Good. You don't want to precipitously increase their blood pressure and blow out any clots that have formed, okay? Increase the bleeding, right? And we also know that giving lots of fluids does what else? What else does giving lots of crystalloids somebody do? There we go, right? Right? You can thin out clotting factors. You can also do what? You can hemodilute their red blood cells as well, right?
So decreased perfusion.
Decreased oxygen, carrying capacity as well. Because our fluids don't, right, crystalloids don't carry oxygen. So yeah, and fluids tend to be kind of on the cool side, right? Room temperature is significantly cooler than what our body temperature is. You can also potentially cause hypothermia if the fluids aren't warmed. And what do we know about hypothermic patients who are bleeding?
It decreases the ability to clot.
There you go. It inactivates clotting factors and you bleed even more. Yeah, so we need to be judicious with our fluids. Let's see here. Repair. If somebody's asymptomatic, we tend to not get worried about these until they're over 5 to 6 centimeters in diameter. So that's about right around there is when we actually start kind of worrying about them and wanting to repair them. In the hospital, abdominal ultrasound and CT scan is going to be the big one. And we may need to administer blood products to these patients. Go figure, right? They're losing lots of blood. We may need to give them lots of blood. You guys okay with that? Some other problems that may occur in somebody who has a compromise of an aortic or thoracic aneurysm, okay? congestive heart failure may develop, particularly if that aneurysm is high enough up on the aorta where it compromises their heart valves. Okay? They may end up having a myocardial infarction. Again, if that aneurysm compromises blood flow to the coronary arteries, right? What's a myocardial infarction?
Perfusion to the
Yeah, it's ischemia gone bad, right? It's ischemia to the point of injury and death. That ischemia doesn't necessarily have to be due to a blocked coronary artery. It could just as easily be due to a rupture above the coronary artery preventing perfusion from going in as well. And then we can also have cerebral, mesenteric, renal, or extremity ischemia as well. Why? Because those organs may not be perfused, right? If the aneurysm's low or it involves the kidneys, you shut perfusion off to the kidneys, maybe they will begin to become ischemic and infarct. If that aneurysm involves like mesenteric vessels that go to our gut, right, it could compromise gut circulation as well. Okay, so you can have all of these other associated problems depending on how bad the rupture is and where the aneurysm is actually located. You guys cool with that? Now, there is another problem called a dissection. You guys heard of that? A dissection is not the same as an aneurysm. In some people, I've heard the term, some people throw around the term a dissecting aortic aneurysm. Have you ever heard of that? Yeah, well,
Dissection is actually the rupture.
what's that? No, a dissection is a completely different problem. Okay, so when you have a ruptured aneurysm, you have a ruptured aneurysm, right? A dissection is very different. Let's talk about dissections, specifically aortic dissection. Okay, so to understand a dissection, we need to understand the layers of blood vessels. How many layers do they have? Three. Okay, they have an outer layer known as the tunica externa. You guys okay with that? That's the outermost layer of the blood vessel. And then the inner layer is the muscular layer, right? Which is known as the tunica media. All right? And then the inner layer is a very slick lining, right? It's a very thin but very slick lining, and that's called the tunica intima. So what happens with a dissection is, for reasons that we don't understand particularly robustly, you get a tear in the intima there. You guys see that there? And you get a tear that kind of separates the intima from the media. And what that does, and what I'll do is I will, let me enlarge this, or I'll draw it over here. So here is the intima, and I have a tear in the intima. And then I have the media here, right here. And then I have the externa here. So this is inside the aorta. This is outside. All right. And so I have a tear, and what's going to happen when I get a little tear? Where's some of the blood going to go? So I have my blood cells. They're going to go into the tear, and then what's going to happen over time? Yeah, as blood gets pushed through this vessel, right? As blood gets pushed through this vessel, it's going to dissect. It's going to just tear it, dissect it, and tear it more and more and more and more until eventually that tear maybe makes its way out through the media, through the externa, and then what happens? Then it tears open, and I have hemorrhage and exsanguination. Does that make sense? Okay, an aneurysm is a little pocket, a pouch, an outpouch, a weakened pouching area, whereas a dissection involves an intimal tear, and then over time you get kind of that dissecting the intima and the media away from each other. Does that kind of make sense? Why they are similar they're similar, certainly their presentation can be very similar, but the pathophysiology is a little different. Same risk factors as aneurysms, but genetic connective tissue disorders play a much more relevant role, specifically things like Marfan syndrome, where they can't produce adequate amounts of collagen in their vessels and things like that. You're going to be at higher risk. Hypertension is a very high risk as well. Okay, just like aneurysms, these are often asymptomatic until disruption occurs. When there is disruption, there are some classic signs and symptoms. Tearing pain, right? You guys are familiar with this, the classic tearing pain. Tends to be severe and abrupt like aneurysms. You can get a pulse deficit. Why might you get a pulse deficit? Yeah. So when you look at your aortic arch, what are the three major vessels that come off your aortic arch?
The first one is the right common carotid bifurcating into the right subclavian. The left common and then the left subclavian, right?
Good. So it's three major arteries, right? So you have, and then here's the aortic arch. So you've got your, right here, your right brachiocephalic, right? And it branches into the right common carotid and the right subclavian, right? You guys okay with that? And then you have your left common carotid and your left subclavian, right? You guys good with that? So this here supplies the right arm. This here supplies the left arm, right? So let's say that my dissection is in here. Okay? And if I start exsanguinating here, that may involve both arms, right? But let's now instead say that my dissection occurs right here. And I start exsanguinating from here. What do you suppose the pressure in the left arm is going to be? It's going to be decreased, but what about the pressure in the right arm? It may be preserved or even elevated. Does that make sense? Okay. So the location of the disruption, okay, is very important there. Does that make sense why? And so in general, when you have chest pain, in general, it's a good idea to check the blood pressure in both arms, right? Look for a pulse deficit. Just like an aneurysm, if this dissection compromises heart valves or coronary arteries, it dissects into a coronary artery, guess what? Your patient's going to present with heart murmurs. They may present with ST elevation and depression, Q waves, right? And so you may mistake this for a STEMI, all right? The problem is, do you want to treat this like a STEMI? No, right? You don't want to give fibrinolytics. You don't want to give aspirin, right? That would be the wrong thing to do, to treat this like a STEMI. Valve disruptions, just like aneurysms, okay? And you can also get neurological compromise. Why? Because a lot of these vessels supply the brain and important nerves with blood supply, right? So you actually can have somebody who is very hoarse, right? Nerves that innervate their larynx and help with speech and articulation may be compromised by that dissection. They may have some difficulty speaking. They can even have stroke-like signs and symptoms if the carotid arteries are compromised, because that's a major part of the, right? That's the entire anterior part of your brain, right? Is in your common carotid arteries, and then the posterior are they come up the back of your spine, your vertebral arteries. You guys okay with that? So how are we going to treat this? We're going to treat it very similar to an aneurysm, but in many cases, people with dissections tend to be very hypertensive. So guess what? We may need to, it sounds kind of counterintuitive, but we may need to give them medications to control their blood pressure. Why?
Decrease blood pressure, decrease volume, decrease possibility of the bleeding.
There we go. Yeah, to decrease bleeding, right? So we may actually need to control their blood pressure to limit the amount of dissection that's occurring. We can do this by giving nitride for vasodilation, and then beta blockers may be helpful because they will decrease the contractility, right? And so the heart isn't pumping as hard into that area that's dissecting, right? So it kind of calms things down a little bit. Pain control may be important, okay? Supportive care as always. And then rapid but careful transport. Yeah, we'll be very careful about how we transport these patients. Okay, all right. You guys okay with that? Right. So in other words, it's if something really bad happens with dissections and aneurysms, there's a whole lot we can do about it.
No.
Not much, other than support them, maintain or manage their blood pressure, and get them to where they need to go. Yeah. But some patients do survive, and there was a very famous surgeon by the name of DeBakey, a famous heart surgeon. Lived in Dallas, worked in Dallas, and he actually developed revolutionary techniques for repairing dissections. And there are two ways that we classify dissections, and it's by where they're located, what area of the aorta is involved. And one of the ways is what's called the DeBakey classification. And there are 3 general classes, 1, 2, and 3. We don't have to memorize them because it's not really relevant to what we do as paramedics, but there are 3 classifications using the DeBakey classification, and it depends on where that dissection is. And a while back, DeBakey ended up having tearing chest pain. And this is, he was almost 90 when this happened. And he ended up going to the hospital, and guess what? He had a dissection, and they used one of the techniques that he had developed to repair his dissection. And he ended up living, and he was almost 100 when he died. Oh, in the last 5 or 10 years, fairly, he was like almost 100 when he died. Yeah,
Recently, that Heimlich actually used his maneuver.
Oh, did he?
Yeah.
Oh, Heimlich. Oh, there you
He
go.
was in a nursing home and
He's probably an older guy too.
yeah,
Right?
he's like 94.
Yeah.
And he saved some lady that was choking.
There you go. Isn't that crazy, huh?
It was the first time, the only time he's ever used it in his entire life.
Serendipity, huh?
Yeah.
It's interesting. Yeah.
Cool.
Yeah. The only reason I kind of bring the whole DeBakey thing up is, well, I was studying for back when I was flying. I had to take a flight nurse. It's a national certifying specialty exam, and you guys might know this guy. His name is Will Wingfield. He started out as a medic here on the ground, ended up becoming a flight medic. Went to nursing school, and he did it was called Excelsior back then, and I think he did it in like 2 months. He just took every test, like 2 tests a week or something. Got his nursing license, and then went into ICU and ended up going to anesthesia school. And he's an anesthetist in El Paso now, a CRNA. And he was doing a conference in Dallas, and he was doing a flight nursing review conference, basically doing a prep course for people that want to take this exam. And he was just talking about dissections and treating blood pressure and that. And he's like, oh yeah, and there are 3 common classifications. They're the DeBakey classifications, but we don't really care about that beyond that. And then somebody in the audience stood up and asked him, well, what if it was in this location? How would this patient present? And he's like, well, I don't know. And as it turned out, this guy was actually Dr. DeBakey, just happened to be in the audience.
Oh, no.
Yeah. So that's why. Yeah. But anyway, completely useless knowledge. But there you go. That's it. That concludes all of our cardiology block. You guys are all now expert cardiologists, right?